It's not just karyotype, of course, it's genomic information that's important. So karyotype and upfront molecular information is critical in determining the optimal therapy. For example, patients with normal cytogenetics and NPM1 FLT3 mutations should be stratified to receive, in my view, GA-GO-based regimens with chemotherapy, and FLAG-IDO is an excellent backbone chemotherapy, superior to what's been standardly used from our data. For patients with adverse risk cytogenetics, then clearly those patients don't benefit from agents such as gemtuzumab. They need to go on to perhaps experimental therapies or novel therapies or clinical trials. And I think it's also important to have the mutational data up front as well, the genomic data. For our AML19 data showing a benefit for those patients with secondary AML gene mutations, and it didn't show a benefit for those with a clinical history of secondary AML. So there was a difference. So a clinical history of secondary AML is not in its way the best indicator for treatment with CPX. We found that the genomic classification, the presence of gene mutations indicating a history of secondary AML, was a much better, stronger indicator for benefit with the CPX. So it's not only, we really need this information within the first week of a diagnosis, not so molecular, cytogenetics, genomic data as quickly as possible to stratify the patient onto the best possible therapy.